Good morning. Our topic for today is all about acute abdomen systematic sonographic approach to acute abdomen in emergency department. So a brief overview for this one is um, we are presenting a case of undifferentiated acute abdomen pain wherein a sonographic approach was applied and facilitated by accurate patient management and disposition. So, acute abdomen protocol was created by the authors in order to aid in the evaluation of acute abdominal pain using a systematic sonographic approach, wherein um, they integrate the same core ultrasound techniques already and into the in diagnosing or the abdominal aortic aneurysm. So this pneumonic acute means abdominal aortic aneurysm, collapse, inferior vena cava. The U stands for ulcer or perforated viscus. The T means trauma, which is usually free of fluid. F is ectopic pregnancy, followed by abdomen, which stands for the A for appendicitis, B for biliary tract, D for distended bowel loop, O for obstructive uropathy, and men for the testicular torsion, and for women is ovarian torsion.
For the patient information, patient A, a 70 years old female Emirati and residents of Oud Mehta Road, Dubai, United Arab Emirates, was brought to Rashid Emergency and Trauma Center at 10 a.m. due to abdominal pain, vomiting, and diarrhea. Rashid Emergency and Trauma Center is the nearest hospital in the patient's district. And for the patient history, the patient is complaining an abdominal pain for 3 hours after eating, and this was associated with vomiting and diarrhea twice. Additionally, there was no urinary complaint, chest pain, or fever. Her present illness is acute abdomen, and she had diabetes and hypertension. Furthermore, the patient underwent a laparotomy, and the patient doesn't have any medications and or any signs of allergies according to her medical history.
So for the diagnostic plan and objectives, we need to have a laboratory, ultrasound, and CT scan. So this is the first image. So for this image, we will have the acute approach. So it will point at the center of the abdomen. So for A, normal aortic diameter. C, collapse IVC, less than 50%. U, no air, no free air. And P is for localized free fluid with donut sign. So you can see that on the first image. So this image is for the CT scan. So we can see here that the abdomen showed evidence of significantly dilated small bowel loops in the right side. And then on the lower abdomen and the pelvis with a short segment, critically stenosis measuring about 2.3 centimeter. It will also show evidence of suggestive of internal herniation with dilated loops of the bowel, and then the jejunal loop and the distal ileum appeared collapsed. So free fluid was seen in abdomen and pelvis. So for the treatment, we need to have urgent surgical consultation was obtained, and the patient had undergone laparoscopy, which was conclusive of unmental band adherent to small bowel mesentery. So about 150 centimeter proximal to the ileocecal junction, producing congestion with punctate hemorrhage and dilation of the proximal bowel of about 30 centimeter. After the band was released, the colon of the bowel exchanged to normal with good peristalsis. So no bowel restriction was needed, and the patient post-operative course 1 was an uneventful, and she was discharged after 5 days. So the patient's symptoms has mimicked simple gastroenteritis had improved, but because of the ultrasound finding, suggested an intestinal obstruction and decided to perform a CT scan of the abdomen. So if not of our preliminary ultrasound finding, this patient would have been discharged without any further imaging. Like we will not do any CT scan.
So for our conclusion, a 70-year-old female was presented with generalized abdominal pain. So laboratory test, ultrasound, and a CT scan was performed. Laboratory test indicated an infection and high plasma lactic acid due to buildup of lactic acid in the body from stenosis. Ultrasound of the abdomen showed localized free fluid and dilated small bowel loop in the right lower quadrant with absent peristalsis. And the CT abdomen with contrast showed dilated small bowel loops in the right side of the lower abdomen and pelvis with a short segment critical stenosis. The patient undergone laparotomy with which was conclusive of an omental band adherent to the small bowel mesentery. After this band was released, the color of the bowel changed back to normal with good peristalsis. So no bowel resection was needed, and the patient was discharged after 5 days. So in this study, an ultrasound can play an important role in acute abdomen by early recognition and diagnosing critical conditions instead of relying on only physical examination, which might have very low sensitivity in comparison to ultrasound. Also, it can guide emergency physicians or any critical care physician in patient management. So that is all for our case presentation. Thank you.